UCT-Africa seminars from University of Cape Town. I can't hear you. Yeah. Today I will talk about sinonasal fibro-osseous lesions. Actually, generally I will talk about fibro-osseous lesions, which are osteoma, fibrous dysplasia, ossifying fibroma mostly, and most commonly we are seeing on our practice. I will start, but it is not. Okay, it's working. Okay. So I will start with a case presentation. This case is 36 years old male. He only had headache for 6 months, used many medications for that, but it is non-responsive to the medical treatment. Had some visual disturbance, but it is not a visual loss or some kind of visual field loss. It's just like he feel a little bit different than usual. No other neurological findings, all cranial nerves was intact. Comorbid disease, there is none. And on nasal endoscopy and physical examination, there was just normal mucosa, no obvious lesions in sinonasal cavity. Then neurological department decided to do a CT scan, actually cranial CT scan. When on cranial CT scan, they found a mass going inside to the orbit, coming from the ethmoid sinuses, and they thought this is probably the reason causing the headaches, and referred to us. As we can see clearly, there is a mass directly going inside the orbit. Here on yellow arrow shows the optic nerve, where the optic nerve is on the left side, and you can see the other side on the right side. This tumor is compressing the optic nerve. So that's probably the reason he's feeling a little bit different. In these cases, we thought this is probably osteoma, and we decided not to go for histology. Actually, in these cases, in these fibro-osseous lesions, I will talk about it later. We are going to do surgery straight away. So that's the surgical video. I will try to keep it shorter, but I hope it will work. So what we did basically is there is two parts of this tumor, ethmoid part and intraorbital part. So there was a not concabulosa, I would say, but lateral part of the concha is removed. Then we can clearly see the uncinate and ethmoid bulla there. We removed the uncinate totally. Then did an ethmoidectomy. Here above you can see the middle maxillary sinus ostium. We did an ethmoidectomy. Here is the skull base. And then we are now removing the lamina. After removing the lamina, here you can see one part of the tumor. That's the part you can see in ethmoid sinuses. For these cases, for these osteomas, you need to drill them. If you can drill them in the midline, and then or the edges, then you will be able to remove them safely. In this case, it's not attaching to the skull base, so we are completely safe. The only problem was it's going inside the orbit. So that means we need to separate the ethmoid part from the orbital part first, because it will be otherwise impossible to resect it one piece. So we just remove the ethmoid part first, as you can see, keeping the periorbita intact. But of course, there is some dehiscence of the periorbita at this side. This is the intraorbital tumor, you can see there. What we do is, with ball probe, we just try to remove periorbita, intraorbital tissues around the tumor, and then gently, also with ball probe, we are just pulling it out without touching. The most important part is not to go so close to optic nerve. If you go close to optic nerve, you will have some reflexes, cardial bradycardies, and just some kind of even arrhythmias, things like that. So you should be very careful not to go very close to optic nerve. Here you can see orbital content is also coming. So we remove the orbital part also, take it out. And then we just put some mucosa, that area, because there is a defect of periorbital. You don't need to do that, but we just don't want it to be stay open. That was the only reason. Okay. After the surgery, we did a postoperative CT scan. This is an early postoperative CT scan. That's the reason you are seeing some bleeding inside the maxillary sinus, but complete removal achieved. And you can see it's clearly that optic nerve is in its original anatomical place right after the surgery. That's a good sign. Specimens you can see here, and histopathological results is osteoma. So fibro-osseous lesions of the sinonasal cavity yield a variety of histopathologic entities. So there are different histopathologic entities. Most common ones are osteoma, fibrous dysplasia, and ossifying fibroma. But other than that, you can see osteochondroma, ameloblastoma, giant cell tumor on sinuses commonly. Osteoid osteoma is the most common sinonasal cavity benign tumor. There is no malignant transformation have been described until now. So it means it is totally benign. So it can be found incidentally in 3% of all CT scans. It shouldn't be just for sinus symptoms on cranial CTs or any other CT scans. You can find it incidentally. They are usually asymptomatic. Frontal sinuses is the most common site of occurrence, followed by ethmoids, maxillary, and we rarely see sphenoids, rarely see osteomas in sphenoid sinuses. They grow very slowly, which can vary between 0.44 millimeter or up to 6 millimeter per year. This is very important because I will talk about the treatment. When we are doing weight and scan therapies or conservative treatments, this growing pattern will be very important for us. So they are very, very slowly growing tumors. Etiology of osteomas is controversial. There are different theories: developmental, so congenital, traumatic, and infectious theories. Congenital theories are saying activated embryonic stem cells, which were previously silent earlier in life. So as a baby, it's silent, but then at the other stages of their life, it's getting somehow activated. The other theory suggests that this is some kind of due to some kind of inflammatory process due to a trauma or infectious disease. There are different histologic subtypes too. The most common one is the ivory osteoma, which is a lobulated, compact, dense bone, which we can see on CT scans and even on X-rays very clearly. Osteoma spongiosum, this is a little bit more spongious cancellous bone than a compact bone, but still it is very, very different than the other fibrous dysplasia or ossifying fibroma. Still some compact bone than the others. Mixed osteoma has a component of ivory and spongiosum, both of them. Which you can decide only the histopathological results, histopathologic examination. It is nearly impossible to say which one it is just by looking at an osteoma or any CT scan. Osteoid osteoma, most commonly asymptomatic, like I said. It's usually incidental diagnosis. But if there is a symptom, it is not due to osteoma itself. It is usually causing a sinus outflow blockage, and that may cause chronic or recurrent acute rhinosinusitis, mucosal. Other than that, facial deformity, proptosis, diplopia, blindness, or intracranial complication. That means even if the patient doesn't have any symptom, and if it is an incidental diagnosis, you don't need to worry about it. But if there is a symptom, you should do something about it. Nasal endoscopy, in some cases, if it is located inside the nasal cavity, not just the sinuses, you can see a nasal mass covered with a normal mucosa. In these cases, it is a little bit difficult to decide if it is a normal anatomical structure, normal mucosa, or a tumor. That's the reason radiological imaging is the gold standard to diagnose it, to be honest. What we are doing is mostly computer tomography scans. It doesn't always have to be maxillofacial CT scans or paranasal CT scans. You can even diagnose it with cranial ones or any others. CT scan shows well circumscribed, very dense, homogeneous cortical lesion. It's very easy to diagnose osteoid osteoma, like we see on that case. Or in some cases, if it is a mixed type or spongiose type, there could be a ground glass pattern, but it is not just only ground glass pattern like we will see in fibrous dysplasia also. It's like I said, usually homogeneous cortical lesion. It will be nice for you to remember it like that, but it will be more than enough. In some cases, we can't do CT scan. In those cases, for example, pregnancies or very small childs for follow-ups, we do MRIs. Other than that, we use MRIs for osteoid osteoma only to evaluate the critical neighboring structures. What I mean is intracranial cavity, maybe in some cases with orbital involvement, or some cases with involvement of postnasal space, things like that. But other than that, you won't need a magnetic resonance imaging to diagnose osteoid osteoma. CT scan is more than enough. I will talk about surgery later at the end, but osteoid osteoma treatment option is primarily based off if the patient has a symptoms or not. If the patient doesn't have any symptom, is asymptomatic, currently general consensus is just wait and scans. Watchful waiting with periodic scans. Periodic scans means usually periodic, once a year or every 16 months, 18 months, CT scan. Like I said, if it is a pediatric patient, you can use MRI scans for that to see the growing pattern. If the tumor is growing more than 1 millimeter at a time, then you can consider surgery for that patient. But another thing is, if the patient is asymptomatic but gets symptomatic in time, then you can also consider surgery. Other than that, in some cases, they are asymptomatic, but the tumor is risk intracranial or intraorbital structures. What I mean is, like the case I showed, it is contacting, so it's compressing to the optic nerve. The patient didn't have any visual loss, but he will get it eventually in years. So that means we can go for surgery for these cases. It could be even for intracranial cases. Some tumors are going behind the frontal sinus posterior wall and pushing the dura. So in these cases, it will be wise to operate before getting a complication. Surgical aim is to complete tumor removal. It is, like we said, it's benign tumor. If you can completely remove the tumor, there will be no recurrences. But what's important is to be able to remove it with preserving neighboring structures. What I mean is preserving all the important neurovascular structures like optic nerve or like dura. So if you think you will cause harm to those structures by doing a complete tumor removal, then you can left some of the tumor on the structures. That's acceptable. And you can just continue to watchful waiting after your surgery. Fibrous dysplasia is slowly growing disease. This is also slowly growing. It's 5% to 10% of all bone tumors. It's basically replacement of medullary bone by abnormal fibrous tissues. We will see more fibrous tissues here. with bone metaplasia than we see on osteoid osteoma. These two are completely different. It usually causes deformation, rarely destruction. So this is also benign tumor. It's not causing destruction, but as many of you probably see, fibrous dysplasia, it's causing mostly deformation. That means aesthetical or facial deformities. You can see there are two clinical types, monostatic and polyostatic variant. We mostly see on sinonasal cavity monostatic variant. Mostly also see 80% monostatic variant, but polyostatic variant, you can see it in craniofacial bone and skull-based involvement more common. What I mean, I will show it. Polystatic variant usually presents earlier in childhood, looks more aggressive, but disease progression after adolescence is rare and minor. So it will just, we are usually seeing in childhood, and if we can keep that patient until adolescence safe, then it won't grow that much more. Monopolyostatic variants presents any time in the first 3 decades of life. Painless, what we see is a painless bony enlargement, which needs facial deformity asymmetry as the most common symptom. But other than that, in these cases also you can see proptosis, diplopia, exophthalmos, visual loss, visual disturbance, cranial nerve compressions, obstructive sinusitis, and headaches. It's actually, these symptoms are pretty similar to osteoid osteoma, but I can say it's usually more severe for fibrous dysplasia. The other difference is fibrous dysplasia can be malignant, can have a malign transformation, which is less than 0.5%, but still there is a risk of malign transformation. What we see, how we diagnose it is CT scans. CT scans is the most important radiological imaging for fibrous dysplasia too. CT scans shows ground glass appearance on remodeled bones. I will show it later. And also for magnetic resonance imaging, the indications are the same. For fibrous dysplasia cases, it will be more relation with neurovascular structures and orbits. So it will be wise to do magnetic resonance imaging if you have access to that. But if you don't, it is perfectly okay to use your CT scans only. Asymptomatic patients best managed again with watchful observation and with scheduled scans. Optic nerve. Other than that, if the patient is symptomatic, surgery is necessary. But I want to say there is a difference what I say in osteoma from what I say in osteoma. In fibrous dysplasia, even this fibrous dysplasia encase any neurovascular structures. What I mean is even it encase optic nerve completely, or looks like it's compressing optic nerve completely. It doesn't mean that will cause visual disturbance, and it doesn't mean that that patient needs surgery. This is the biggest difference the fibrous dysplasia having, because studies show even if it encased the nerve or the vessel completely, vascular structures completely, it doesn't cause any harm, and it doesn't cause any neurological symptoms in most of the cases. Like I said, but in these cases, if you see there is a relation with a neurovascular structure, then you need repeated examinations from a specialized department, like for optic nerves, ophthalmologic examination, or like for carotid artery, you can talk with neurosurgeons. And should be also part of long-term radiological follow-up. This is very important. If you have a patient who you can't follow up radiologically yearly, or if they are not keen to go for a long-term follow-up, then you can also consider, I think that's also a surgical indication for that patient. Current evidence indicate, like I said, surgery has no role for prophylactic optic nerve decompression. This is very important. Once patients become symptomatic, then, or if they have cranial neuropathies, any kind of symptoms, then you should go for surgery. Surgery just aiming to decompression. So if possible, complete resection is the cure. But if you can't, like I said before, the most important part is not to cause any complication. If you think you will cause a CSF leak during the surgery, then just left some of the tumors at that site. It will be much more safer than doing that surgery. Ossifying fibroma, this is much rare than the fibrous dysplasia and osteoma, but it is still one of the common fibro-osseous lesion in sinonasal cavity. It's also painless, but it is characterized by aggressive tumor growth. Ossifying fibromas are very aggressive. It causes controlled deformity and loss of anatomical structures. So you can't find your anatomy in those cases. The juvenile form is more aggressive. So we will see it on the childhood where it is much more aggressive. Juvenile form has two subtypes. One is psammatoid, other is trabecular. Trabecular lesions usually we see on mandible. Psammatoid lesions is sinonasal cavity, orbital bones, and it can start anytime. But it is, like I said, usually juvenile age, so it will be a childhood disease mostly. What we see is it is aggressive, nasal obstruction, all kind of cranial deformities, cranial nerve deformities, facial deformities, facial asymmetries, headaches, sinonasal other diseases. Diagnosis is the same. CT scan is important as round, oval, expansive masses with multiple loculations. That's the difference. It has multiple loculations. Some of them had some calcifications and cysts inside it. It is basically, it has a thick bony wall, and if you open that thick bony wall, you can feel it's a soft fibrous tissue core, I would say. Sharply defined outside margins, so like I say, thick bony walls is the most important radiological sign for a differential diagnosis from fibrous dysplasia or any other malign tumors. Treatment is whatever it is. If you think it is ossifying fibroma, or if you take biopsy, it is ossifying fibroma, you have to go for a complete surgical removal. And what I mean is complete surgical removal. Otherwise, you will have recurrences. Recurrence rates are really high. In these cases, we are not trying to stay as a minimally invasive. The most important part is to cure that patient. For surgeries, what are we going to do? If there are symptoms like we talk about, we are doing planning our surgical approaches mostly due to surgeries and mostly for the other reasons I will explain. For endoscopic surgeries, it's usually pain, ocular symptoms, neurological changes. If it is like that, and if it is a limited disease, you can go for endonasal endoscopic surgeries. But if you have cosmetic concerns like facial asymmetry, facial distortion, open approaches, or if you need any kind of reconstruction, open approaches is the best choice for you. This is a patient, you can see it's a maxillary sinus fibrous dysplasia compressing the orbit and restricting the orbital movements. We go for this case with mid-facial deglowing approach. So put a mesh, titanium mesh, because when you remove all that tumor, you will have to remove the orbital floor. If you remove the orbital floor, that means you will get an ophthalmos. And in this case, it is unfortunately not so possible to left some tumors inside it. Behind it, because then you can't decompress the orbit. This is the most important part. So then we decided to remove it completely, go for a titanium mesh, just for reconstructive purposes. Like I said, probably fibro-osseous lesions in frontal sinus, in maxillary sinus, or in anywhere in facial bones. Is the most important or most common indication for open approaches for sinonasal tumors. Another thing is, if you are deciding to go for endoscopic surgery, there are some important things you need to reconsider. One is pathology, because you can choose different strategies, different approaches according to pathologies. For osteomas, for example, attachment point will be important. For fibrous dysplasias, there will be bleeding. They are bleeding. For ossifying fibromas, high recurrence, like I said, if you think you can't resect completely, then please don't go for a endoscopic approach. Other important factor is lesion size. It could be very big. As you can see, it's going to corner. So if you think you don't have proper equipment for this lesion size, or if you think the attachment point is so close to skull base or somewhere, and that you will cause some kind of complication. As you can see here, there will be anterior ethmoid artery, skull base attachment. Then you should be very careful to choose the endoscopic approach, or performing that endoscopic approach. Another thing is avoiding future problems. Like I said, this is here, you can see a tumor. It's going to orbit. It's just pushing the orbit laterally on the CT scan and MRI. You can watchful wait and scan these patients, but that doesn't make any sense. At some point, this patient get orbital symptoms, so it will be better to resect this. And in these cases, also endoscopic approach will be best method. We will do basically the same thing here, but as you can see, it's not going as much. It's not working, I guess, as much inside the orbit than the first case. I will just skip it. But yeah, it's not working. Another one is attachment points. Here you can see a fibrous dysplasia, a big one causing frontal sinus obstruction. It's just obstructive frontal recess. This patient also only had headaches and nasal obstruction. As you can see, its nasal cavity is full of tumors. But it is a risky surgery because there will be anterior posterior ethmoid artery. It's attaching to, like you see here, cribriform plate, so the skull base. And it is on posterior. It's also very close to internal carotid artery, lamina attaching to lamina papyracea laterally and orbita. So that means it will be a difficult surgery. In those cases, you can think of lefting some of that patients. In these patients, we decided to do complete resections, which I wouldn't do if I have to now, to be honest. It's an old case because I caused a CSF leak and I repaired it. After that, it happens again. So the leak continues and I need to go for a CSF leak repair again. Patient is doing fine now, but it was not an optimal treatment, I'm thinking. The location, the frontal sinus, like I said, for osteomas is mostly located in frontal sinus, and if it is in the frontal sinus, that's very difficult to decide what to do, because in the frontal sinus, removal of osteoma could be very challenging. What we are doing is we are using the frontal sinus drill out procedures, either type 2B or type 3, and newly there are different methods for transorbital or transnasal orbital retraction or transorbital surgeries or transfrontal surgeries. Or you can think about combining two open-end endoscopic approaches in these cases. If you think you don't have enough instruments to go for draft 3, or you won't get enough opening for that, or if you don't have angled instruments like angled drills. So then if you are going for frontal sinus surgery, the most important thing is be sure that you left enough drainage after the surgery, because each time I did a frontal recess or frontal sinus surgery for osteoma or fibro-osseous lesions, I get a pathway closure 1 year later, 6 months later or so. That may cause mucosal or things for you, so it should be nice to keep the pathway open if possible. Another location is that sphenoid sinus. You can see here a sphenoid sinus fibrous dysplasia. It is it's actually extensive disease, all that covering all the very close to optic nerve, very close to internal carotid artery. This patient only had medication resistance, non-responsive headaches. So previous for years ago, we were going surgeries for these cases, as you can see here. This is a postoperative second week complete resection, but nowadays they don't suggest to go for surgery right away because they don't think that headaches is caused by this tumor. So you guys need to be very, very careful about what to operate on if you have a tumor in sphenoid sinus. If you think you tried everything, you tried every medication, and that patient still had some complaints, then you can go for that. But if not, try to go for watchful waiting and some medication for headaches. It will be nice to cooperate with neurological departments or algology for how to reduce the headache to help patient. So to conclude, most of these cases, for most of fibro-osseous lesions, we will only do wait and see with radiological follow-up. What we are doing is yearly radiological follow-up. You can choose which one you can follow up with CT scans or MRI. It's up to you. Endonasal endoscopic approach is valuable for most of cases, especially if you want to do a minimally invasive cases. It is a nice option. But like I said, in cases with ossifying fibroma, you should be very careful to go for a minimally invasive because recurrence rates are really too high. Different strategies required. You have to be careful and evaluate all that options according to pathology, size, extent, attachment points, anatomical compartments, and the involvement of closed neurovascular structures. Another concept for the management is some should minimize the intraoperative complications. We don't want the patient get CSF leaks. Bleeding is during the operation, that's acceptable, but after the operation, bleeding will be not preferable. So postoperative complications, like I said, there will be pathway closure and inflammatory process. If possible, it would be nice to open it as big as possible for these cases, sinus openings. Thank you for your attention. If you have questions, I can answer it. There are chats. Illustration. Our video is not working, huh? Yeah. These are on the first line still. It says. Okay. Participants. But we can see the details in here. And they should be able to see it also.
Well, can you unmute?
I did. Mute all. And unmute. How to do that?
Hello, go there.
Here. I think there will be a problem with the presenters. Let's see, first slide.
You see?
Could be that's the problem. Maybe I did it again. Let's see. But we can share it to online so they can see it there. Huh? I think you can say that we will share it online. Because I think we did a code. Here is not the problem. I think the problem was with its slides.
Oh.
I don't think they don't any more input. I think there is no question, so we will end the session. Have a nice day, everyone.